Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities: the Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community. And welcome to today's episode of Spark Live. I'm Doug Maynard, an Associate Director at Children's Healthcare Canada. And Spark Live is our webinar series where we curate and convene and showcase excellence and innovation from across the child and youth healthcare community to spark conversation, ideas, and action. And since we are live in these sessions, I do want to remind everyone that you do have the opportunity to type questions into the question box at any time. We will check for questions throughout, so please don't feel you need to wait until the end of the presentation before you start typing the questions. Just go ahead and put them in as you think of them. And also feel free to share any of your thoughts on Twitter, and be sure to tag us at Child Health Can. All right, so today we're talking about empowering women leaders in health. Certainly empowering women and equality and gender rights and equality, not an issue unique to healthcare. We hear about it in the media regularly now. Well, what's going to be interesting today is we're going to be talking specifically about healthcare, but we're going to be looking at it from a research lens. So we have some experts in the world in this world who have been doing some actual research, and they're going to share with us some of their research and some of their thoughts on this issue. So, without any further ado, it's my pleasure to introduce Dr. Lynn Bourgeault. Ivy is a professor in the Telfer School of Management at the University of Ottawa, and she also holds the CIHR Chair in Gender, Work, and Health Human Resources. She's also a member of the Canadian Academy of Health Sciences. So, and Ivy has a team with her who will be participating in the question and discussion at the end, but we'll be hearing mostly from Ivy. So it's my pleasure to hand the virtual podium over to Dr. Lynn Bourgeault.
Good day. Thank you so much for that introduction, and I'm really pleased to be able to present to you about our ongoing project entitled Empowering Women Leaders in Health, where we're focusing on three domains of healthcare, health sciences, and the intersection with a specific focus on Indigenous health. So I just want to introduce a little bit of our team. You had a bit of introduction from myself. Our co-lead is Dr. Karen Lawford, who's an assistant professor at the Department of Gender Studies at Queen's University. And Karen is our project lead for Indigenous health leaders. We also have two doctoral students working with us, Yvonne James and Jamie Lundeen, who are both with the Institute of Feminist and Gender Studies here at the University of Ottawa, and they both work in our research lab on gender, work, and health. Yvonne has been specifically looking at roles in maternity care, and Jamie within academic health sciences. And we also want to acknowledge our partners at the Canadian College of Health Leaders, at the Canadian Health Leadership Network, and in Leeds, Canada, Kelly Grimes, who's the Executive Director at CHLNet, and Brenda Lammy, who is with Leeds, Canada. And we are very much working in partnership with them so that our project aligns with a lot of the leadership initiatives at CCHL, CHLNet, and Leeds, and as a way to mainstream, because we are a 3-year project that will be coming to a close at the end of 2020, and we would like there to be a legacy, so Kelly and Brenda are very important in that regard. So just to give you an overview, we talked a bit about our team and partners already. I'll give a little bit of an introduction to the call for proposals from Status Women Canada, which is more about an action project than it is a research project, although we are researchers and we will wrap that around it. I want to introduce our leaders, which was part of the call, the objectives, and then looking at some of the activities that we've been undertaking in terms of the scoping review and the framework that we've developed, the toolkit, learning labs, social media, and then a project which we're sort of doing off the side of our desk, looking at gender representation and health leadership. So we responded to a call for proposals from Status of Women Canada, which is now the Department of Women and Gender Equality. So it has shifted status during the time of our project. And they had a call to identify women leaders in various sectors, organizations, and communities, and to engage them in local projects to advance gender equality. And I want to highlight the local projects because our project is to focus on the province of Ontario. That is where we get our funds. So the call it aims to identify and engage a total of 150 women leaders from across the country to mark the 150th anniversary of Confederation in 2017. And these 150 women leaders compose the Gender Equality Network Canada. So that's one parallel activity. So in the project that we put together, we said, well, we're going to look at these overlapping spheres of healthcare, health sciences, and Indigenous health. And so one of our first tasks was to identify leaders in those three domains to contribute to what we had identified earlier, the Gender Equality Network. So I want to give a little bit of justification for why we chose those areas before we get into who our leaders were. So in healthcare, women hold a unique position. They constitute over 80% of the health workforce, yet they hold fewer leadership positions. And in fact, healthcare is really quite remarkable. It is the sector where women largely work. It is the most gendered female sector. And so if you're interested in women's work, you should focus on the health and social service sector. And so we got inspiration from a recent UN high-level commission that was co-chaired by the President of France and the President of South Africa. And this commission looked at health, employment, and economic growth. And they had a set of calls for action to maximize women's economic participation and foster their empowerment through institutionalizing their leadership, addressing gender biases and inequities in education and the health labor market, and tackling gender concerns in the health reform processes. So this is something that was very much an inspiration. So just to give you a little bit of background about how gendered female the health workforce is in Canada, the red line here in the graph shows the increase in participation across the labor force. So there has been an increased participation. So that cuts across men and women. Looking specifically at men and health, there has been, again, a larger increase, 74% increase of men's participation in the health sector. So by and large, there's an increase in the health sector. But look at the yellow line for women. So women predominate and are increasing. And how that is happening is that there are more women going into what were traditionally male occupations of medicine, dentistry, pharmacy, chiropractic, etc. But you haven't seen a huge increase in the number of men going into traditionally feminine roles in healthcare, such as nursing and midwifery. So, but it's important to note that, again, this is the area where most women work. But do they end up in the positions of power? And this was just an article that came out in Healthy Debates, that in healthcare, do the people in power reflect the people that they serve? And so this is starting to become questioned. We don't have excellent Canadian data on this, which we'll get to the benchmarking activities that we're doing off the side of our desk. But here is a global health leadership pyramid that was just produced by our colleagues at Women in Global Health. And so it's a representation pyramid. So these are some examples that they chose in terms of how many Fortune 500 healthcare CEOs are women, 3.7%. But then you go down to the bottom, there, and the long-term care workforce is 90% female, and you see all the gradations in between. So this is the global health leadership pyramid, but I would say that this is the health leadership pyramid in Canada, which we're trying to create. So we also wanted to look at health sciences, and particularly that intersection between healthcare and health science, the science of healthcare, less so about women in STEM. And there were a number of projects funded with this call looking at women instead, but we were particularly interested in that area where, again, there's a lot of women. So women's leadership in health sciences is critical to advancing scientific inquiry, which can be of unique interest to women scientists. It is true that women scientists often ask different questions and therefore generate new knowledge to improve health and healthcare. And so looking specifically at the issue of research funding within health sciences, women are far less likely to receive competitive Canadian Institutes of Health research funds. The most prestigious foundation grant, they were 1.5 times less likely. And when funded, they receive significantly less research funds. And we have some references to colleagues who've been doing this research. Gender also influences the authorship of research publication, even as teams. So in leading U.S. medical journals, women were only 29% of first authors, 19% of senior authors, and only provided 11% of invited guest editorials. We are partnering with some organizations, leading Canadian journals to look at these data here. And here's just a little graphic from CIHR funding in terms of the likelihood that you will get funded and the amount of funds that you actually receive. So again, women were less likely to receive funding, but if you look at that first chart, the male applicants receive 81%. This is just another graphic to kind of represent, what is going on here. So there are some issues in terms of gender equity in health sciences. In Indigenous health, a really important and incredibly invisible sector, it reveals a similar gap, contrary to women's traditional leadership roles in Indigenous communities. Gender inequity is enshrined in the Indian Act. It's a very not only colonial act, but a very patriarchal act. And so there are additional constitutional contextual reasons for the gender inequity that we see in Indigenous communities. Women's leadership within Indigenous communities can begin to respond to the calls to action from the Truth and Reconciliation Commission to increase the complement of Indigenous health workers, both to provide culturally competent and appropriate care to their communities, but also as a source of high quality employment. And we have data there. Presently, Indigenous health workers comprise 2.2% of the Canadian health workforce, in contrast to there being 4.9% of the population, according to the 2016 census. But again, they are not in sort of the leading roles or the leading professions. And in fact, some of those data mask, for example, in Nunavut, less than 5% of the health workforce are from Inuit backgrounds. So this is a very important area to look at. And just to remind everybody about what the calls to action are from the Truth and Reconciliation Commission, which we have taken upon identifying our responsibilities to move that forward. So under Section 23, we call upon all levels of government to increase the number of Aboriginal professionals working in the healthcare field, ensure the retention of those Aboriginal healthcare providers in Aboriginal communities, critically important, and then providing cultural competency training for all healthcare professionals. So even though we are providing support for Indigenous women and Two-Spirit leaders in healthcare, we also want to ensure that all women leaders and all leaders in general have cultural competency for those leadership roles. So just to introduce the leaders that we proposed in response to the call from Status Women Canada. In the healthcare sector was is our leader, Jillian Carnahan. Dr. Carnahan is the president and CEO at St. Joseph's Healthcare London, a teaching hospital in London, Ontario. And at the time, Jillian was the co-chair of the Canadian Health Leadership Network, one of our key partners. And Jillian has been a wonderful healthcare leader to work with. Our health sciences leader is one of my mentors, Dr. Nancy Edwards, who's a distinguished university professor here at the University of Ottawa, and worked for 2 terms as the scientific director of the Institute for Public and Population Health at the CIHR. And Nancy is leading in this area of health sciences, in particular that, the science of healthcare and public health. And our Indigenous Health leader is Dr. Lisa Richardson, who is an assistant professor at the University of Toronto and holds the Wilson Center's Indigenous Health Education Investigator Award, and works meticulously with the Royal College of Physicians and Surgeons Indigenous Advisory Committee. So these are our 3 leaders that we put into our application, invited to contribute to our application and lead these particular areas. And again, the second element of this, in addition to the Gender Equality Network, was to undertake activities to bring about systemic change to the barriers that contribute to gender inequality. And so we wanted, and also to develop and maintain active and effective partnerships. So it was really to create a community of practice for women leaders in these 3 domains, focusing on activities in Ontario, but keeping in mind that our partners are pan-Canadian and who are very interested in working with people all across the country and affecting change that way. So I want to just pause here for a moment just to kind of unpack some of the notions of gender. And how gender is a social construct. And sometimes we refer to, sex and gender-based analyses, and how sex refers to more of the biological and gender more of the social. So wanted to, because it has an important impact on how we examine leadership. So gender as a social construct refers to socially prescribed and experienced dimensions of being female or male in society. It's manifested at many, many different levels. It's intimately connected to social, political, and economic status, in that maleness, masculinity, is almost universally preferred over femaleness or femininity, and it is privileged. So it's both preferred and privileged, and it's very important to acknowledge that. Gender is multidimensional, such that it is culturally based and historically specific, and therefore constantly changing. So our depictions of maleness and femaleness can be changed. And this is what's emancipatory about understanding gender as a social construct, is that it's not a given, it can be changed. And that's what we wanted to undertake in this project. So when we look at a little bit more about why, look at leaders. There's this notion of the social and cultural construct of what is a leader. So does she look like a leader? Not if she's a woman, studies show. So again, recent article. So if they had asked, children to draw a picture, and most likely the picture was going to be of a man. And there are a variety of different assumptions that we have about women and leadership and the pathway to leadership. Things like, well, we've never hired a woman for this position before. Will your kids get in the way? Don't take it personally. You have a lot of experience, but we're looking for someone who has more authority, which again may not be associated with femaleness. We need someone who is going to be tough, but you're good at taking notes. We didn't think that you'd want to get a sitter. All of these other types of assumptions and so this is a group in Australia that's talking about lead hership. To really focus on from a gender perspective. So the overarching objective of our project is to understand how the increased participation, visibility, and advancement of women in leadership positions can achieve transformative systemic change in these domains of healthcare, health sciences, and Indigenous health contexts. So, but we weren't as naive as saying, just if we just increase the number of women, stir and everything's going to be wonderful. You have to provide resources for women and for men also to mentor and to sponsor women. So it's not just about getting more women to the table, but how they change that table by putting issues on the table that are about transformative systemic change. So it's not just an equity and diversity and let's get representation there. Let's have difference in terms of what is going to be discussed. And we use this graphics to talk about equality versus equity. So we use equity quite purposefully. So equality is everybody gets a box, but you still have inequity. Equity gets at distributing the boxes differently so that everybody is in the same way. But the third panel is what we feel is most important, is you've removed the systemic barrier. And so that's where we want to get to. That's our path. And although we've been using the term gender here, I really want to highlight the importance of intersectionality, and that although we foreground sex and gender, we understand that there are multiple social identities, including race or racialization, sexual orientation, social economic status, and disability, and they intersect at a variety of different levels, from the micro individual experience level to the meso-organizational level to the macro-social societal level. And so we really want to keep this lens open explicitly, because again, it's not just getting women to the table. If they're all going to be white women, we need to get diverse groups of women to the table. So our goals is to build and sustain capacity to create a community of practice through two interrelated objectives. So developing a strong and supportive network and community of practice among established and emerging women leaders, about leading from where you are, not just only about positional authority, although we do want to get women in positions of authority, but leading where you are. Enhancing their capacity to make transformative systemic change, providing them with the tools and resources to do that. And those tools and resources, we want them to be evidence-informed insofar as is possible, so that we can build capacity for transformative systemic change through this network of leaders. So those are our two goals: creating a network, community practice with some tools to really create systemic change. So some of the activities that we've been undertaking is for that evidence-informed nature, scoping review, plus interviews with women leaders to understand their path to leadership, what were the barriers and facilitators, and what helped them in their journey, and what do we find in that regard from the scoping review. So to create a framework, and then using that framework to inform a toolkit of promising practices. And then we've applied those in learning labs to support different women leaders initiate and sustain systemic change projects in their organization, which may be as small as their research lab to the actual organization for which they are on a board. And then also to create a sense of community through social network to support leaders. And then benchmarking is really for us to be able to identify where are women in the positions of hierarchy in healthcare, health sciences, and Indigenous health. So in terms of the scoping review, we shortlisted key articles from the published and gray literature, created this list of must-reads. Here are really high quality, and then that was shortlisted and augmented with the gray literature. And so in doing the scoping review, we created what we call buckets. We had a literature extraction tool to categorize the barriers and facilitators and promising practices. And here are some examples. And then that all got constructed into a framework that was informed by how gender is constructed, and the impact that the social construction of gender has at various levels, including from the macro level about how society is organized in terms of social norms, institutions, structures, and resources, at the meso-interpersonal or organizational level, how that happens, and then micro at an individual identity and values level, and really trying to stress that gender neutrality is not possible. It's a myth. So we created this framework of barriers and facilitators. So on the one side, the barriers, on the other side, the facilitators, at each of these levels: societal policy level, the organizational team level, and we might kind of discern that apart a little bit, and then at the individual level. And so we have some examples that emerged from the literature and from the interviews that we did with women leaders. So for example, some of the organizational level barriers there being, recruitment and this notion of a glass ceiling. Women can't get beyond, a certain position. Or another really interesting concept in terms of retention, or the glass cliff, that women might only be recruited into a position because they are destined to fail. So the glass cliff. And my best example there is, Theresa May and how she's trying to move Brexit through. That has been a glass cliff for her. But other organizational barriers in terms of sexual harassment, caring dilemmas, that means, sort of you're balancing between the care at home, sometimes the care work that you do at work. And so we really wanted to shift our focus on saying, these are the barriers that we know. How can we think of those in much more of a facilitative or promising practice way? And so again, at the organizational level, policies around sex and gender-based analysis, there's a whole conversation in the literature about targets versus quotas, soft and hard targets. Looking at mentoring and equity and networking programs that might be gender-based, gender-focused leadership opportunities, and other promising gender-based organizational practices, particularly, for example, around scheduling of meetings and that sort of thing. We did identify barriers and facilitators at the individual level, but we really, again, wanted to move our analysis and our point of intervention and actions up to the team and organizational level, because that had greater promise for systemic change. But we do appreciate that we also need to kind of look at, the particular attitudes and behaviors of individuals. So that framework then led to the creation of a toolkit. So we didn't want to just produce the scoping review as a report. We wanted this to be really action-oriented. And so this is a toolkit of promising practices that are evidence-informed, so it's based on the literature, in support of advancing women's leadership and taking on particular systemic change initiatives. And so we've extracted those shortlisted articles, and we created sort of 3 different toolkits, which we've now merged into one because there was so much overlap, but some of the specific examples might be more pertinent to healthcare or health sciences or an Indigenous health context. And so we start with sort of a face sheet. That's kind of a 1-page overview of the different promising practices according to the framework. So we have 12 promising practices where we have 3 at the individual level, 6 at the organizational level. We've emphasized that because of the impact of that on more systemic change, and then 3 at the macro policy level. And then we created for each of those promising practices reference sheets to provide more information about how to implement those promising practices with a particular focus of the healthcare, health sciences, Indigenous health context. So that's still in the process of being updated. And so Jamie and Yvonne, who are online and can speak to some of these issues, have crafted this and merged it together. So just to give you a bit of an overview, but if you have additional questions, we're just giving you a snippet of a couple of examples each, but they can speak to the other examples that we have of the promising practices. So at the individual level, it's about thinking strategically. And one of the examples is about how we build mentorship into the workday. That mentorship shouldn't be off the side of your desk. And mentorship is not just about seeking a mentor, but also being a mentor. And we really love that we have advice from women leaders like Mamta Gautam, who has said, you don't need to be monogamous in your mentors. You can have more than one, and they can be quite strategically chosen. And the difference between mentorship and sponsorship, sponsors open doors for you. And so you kind of have to think strategically about this. And mentorship needs to be an ongoing process built into the workplace, and engaging mentoring across disciplinary, institutional, gender, and diversity boundaries. And so really taking it upon yourself for, we are also encouraging men to be mentors for women, white women to be mentors for Indigenous women, racialized women, women living with disabilities, etc. So that's just one example about an intervention or promising practice at the individual level about thinking strategically. At the organizational level, we're encouraging them to think systemically. And we're going to have two examples here because that's where we have the bulk of our cases. Is going about establishing gender and diversity aware or sensitive hiring and promotion practices. How is it that you go about that in establishing committees? How are committee members who make these decisions informed? How do you go about setting targets or quotas, challenging this notion of tokenism? Well, we already have one woman of color on this committee. We don't need another one, type of thing. But tracking progress and making this public for accountability and transparency. If we don't count and if we don't make those counts public, there's no transparency and there's no impetus to make things different. And that we'll speak to that when we get to the benchmarking and counting study that we're doing off the side of our desk for this project. And it's not just about you. If you subcontract out your hiring and promotion practices, make sure that the companies that you engage in are also attuned to your equity, diversity, and inclusion initiative. And it's not a one-off. This has to be built into all of the activities that you're doing. It's not a tick box. So that's one of the promising practices. And another one at the organizational level is changing to a much more gender-based organizational culture, something where there's awareness. So recognizing women's care work at home when scheduling meetings, events, and networking opportunities. Share the less recognized and valued, what we quote call care work tasks across members of your organization. So it shouldn't always be the women taking the notes of the minutes of the meetings or getting the coffee or arranging for the food or all of that type of stuff. And challenge the implications of the emotional care work that women perform for colleagues and superiors in terms of, the impact on burnout and stress. So these are just some examples. And then if we have leaders who can think more structurally at the societal or policy level, if they have those opportunities to be on those committees, one example, promising practice that we have highlighted and adopted is the Athena Swan program. It's a charter for recognizing women in STEM careers, but it does apply across academia and across, the health sciences area that we're looking at. And in fact, this is being adopted in Canada. So we had asked for that to be adopted, which was great, and it is in the process of being adopted here in Canada, not so much through Accreditation Canada, but through the tri-councils. So watch this space because there is external agency support for looking at gender and diversity. What's really great about how it's being adapted in Canada is they're not only looking at gender, but the other employment equity groups of racialized persons, persons living with disabilities, and Indigenous persons. So keep an eye on that because we, again, all have to affect that process. So what are we trying to change? We're trying to move from individual change to institutional or systemic change, and from more informal to formal, although the informal is really important for culture, but it's really important for us to think more systemically about this. And we do this in part through the Learning Labs, where we support women leaders to take on a local, an identified systemic change project. And so we've had two so far. They've been combined in terms of healthcare, health sciences, one in Ottawa and one in London, Ontario. Again, our funding was to focus on Ontario, but we're quite happy to partner with people to do this elsewhere. It was a 2.5-day activity where we give some introduction, as I have described here. They start working with mentors to identify their individual projects. So it's group work to support their individual organizational systemic change project. We give them an overview to the toolkit and really kind of walking through those resources and how they might build upon those. We have some great stories and inspiration from women leaders in healthcare and health sciences. And then we also, for the last two, have had women leaders in the Indigenous Health context, ensure that all of our women leaders are sensitive to those issues. And we will have a dedicated learning lab in May for Indigenous women leaders. So in Ottawa, in addition to our health sciences leader, Nancy Edward, we'd had excellent women leaders, Mamta Gautam, Paulette Senior, Val Gerdsa, and Carrie Barassa spoken. There are all videos, and they are just about to be released on the Canadian College of Health Leader website. So do the space that they have provided for our Empowering Women Leaders project. And in London, in addition to our healthcare leader, Jillian Carnahan, we had Dr. Gigi Osler, Dr. Mitu Sen, Dr. Josephina Toa, and Candace Burnett de Bassage, who is doing her PhD, so it's not a doctor yet. Brilliant presentations there, speaking around their stories, and again, those will be posted. Upcoming events, as I mentioned, is we'll have our third Learning Lab for Indigenous women and two Spirit leaders, co-hosted by our Indigenous leader Lisa Richardson, and our project co-lead Karen Lawford. That will be May in Sudbury. We are presenting, we hope, at Women Deliver, a gigantic international conference that we're hosting in Canada, in Vancouver, in June. And we will have a workshop at the National Health Leadership Conference in Toronto the following week, so early June. Just to give you a sense of social media networking, we have a presence on the Canadian College of Health Leaders website, LinkedIn. I think some of those numbers might be a little out of date, and Facebook. I updated the Twitter ones. We're really, really hoping to get to over 1,000 followers. We're quite active at certain times. So we had, for example, there when we had our second Learning Lab in October, we had a lot of impressions, especially through our leaders who were tweeting a lot. And that's just a little bit from our social media and our logo, which is about, diverse women breaking through, and not just one going through, but bringing people, other women with them. Just to kind of round us off in terms of the work that we're doing off the side of our desk, but we're really hoping to do more of this, is benchmarking women's representation in leadership positions. And it's really, how do we define that? Is that by CEOs or senior management of the different types of organizations, professional associations, regulatory bodies, women's leadership in the C organizations or the C-suite, boards, hospitals, LINs, in the Ontario context for now anyway, community health centers, family health teams, public health units. So there's a variety of different places that we can look at. When you look at, sorry, I think I just missed, there was something that was lost there. The proportion of healthcare providers by year, this was just to note that there has been an increasing proportion of women in the different healthcare provider roles in terms of, for example, dentistry and medicine, etc. So my apologies for the graphic not showing up. But it's also to look at unpacking workload differences by gender and getting back to this issue of assumptions that we have. So if you're looking at family medicine or medical and surgical specialists, for physicians, you do see that women have a lower average FTE. So, but we can also interrogate how it is that they go about calculating an FTE. So there's a measurement issue, but let's just park that for a moment. Even in occupational therapy, if you look at weekly hours worked per week, it is lower for women than for men in that occupation. So that has an impact on, being picked up for leadership. Why that might be the case, again, we need to acknowledge the lives that women have outside of the home. This is, from a global perspective. Even in developed countries where we have supposedly greater labor force participation for men and women. Women still do more unpaid work than men. And this is a graphic that I had to use in the presentation today. This came around Twitter because this is, and it's from a graphic artist who's Spanish, but just to note that these are the extra kind of hoops that you have to go through. My colleague Imogen Coe talks about it not so much as the glass ceiling as it is the glass obstacle course to leadership positions. I had sort of said on Twitter that we could add a few babies and other things in there, older adults that we care for in that graphic as well. So then when you see in terms of representation in teaching positions by men and women, you see the disparities there in terms of gender. And again, although we are approximating 50% of women in dentistry and medicine, they are not there. The most extreme case there in terms of faculties of medicine is that we have had 5 female deans of the faculties of medicine in the history of Canada. There are 17 medical schools, and medical schools have been open for over 100 years. So that's a pretty stark point of data. The leadership in pan-Canadian health organizations like the Canadian Institute of Health Information or Canada Health Infoway, there's much greater representation there. But then when I showed this slide to someone, they said, but you need to kind of unpack that a little bit because the women are the CEOs of the smaller pan-Canadian health organizations, not the larger ones. So even there seems to be an issue. Women in CIHR research leadership positions, and these were data that we got in 2018, is that 23% of the scientific directors at CIHR are women. And I think that may have actually gone down since we collected that. So we want to get from gender inequity to greater gender equity through moving from gender unequal or this notion of gender blind, so that ignores gender norms. That doesn't get us anywhere. We need to be more gender sensitive, gender specific in an equity focused way to get to gender transformative. And this is from colleagues Lorraine Greaves and Pedersen's work. So what do we say a more gender equitable future looks like? Equal representation of women in leadership positions. So equal representation of women, but then we also need to have equal representation of the health codders in leadership positions. So if all of the women are physicians and we don't ever get women who are nurses and occupational therapists and midwives into leadership positions, there's still inequity. We also want to get equal remuneration for work of equal value, and in the health sector, the gender pay gap is huge. We can speak to that in the question and answers. Zero tolerance for sexual harassment and violence. There is a campaign out right now about the amount of violence experienced by nurses. And I believe last week there was an expose on the level of violence experienced by personal support workers in long-term care. So zero tolerance for that. So the Me Too movement has definitely had an impact. That's been talked about perhaps more so in medicine, but it's endemic across the health sector. All health workers and health work valued equally. Employment and social policies conducive to women's labor market participation and conducive to women's participation in leadership positions, and that care work is formally recognized and compensated both within and outside of organizations. So that concludes my presentation, and I'm really happy to get questions and very happy for Yvonne and Jamie, and if Karen is online, to respond to some of the questions. So thanks, everyone.
All right, thank you, Ivy. Great presentation. Really brought an evidence lens to this issue that we hear so much about. So that's really a great addition to this conversation. So as Ivy said, any questions that you would like for either her based on the presentation that she's given, or her team, who are also sitting in the wings waiting to participate in the conversation. And for the team that's waiting in the wings that we haven't heard from, please do feel free to jump in at any time. Your microphones should be live as long as you've unmuted yourselves. So the one question that came in sort of very early on in your presentation was just someone, I get the sense that she might be a social worker. She's wondering what you think about the idea that certain health professions are gendered, sort of looking at maybe your observations across the different professions within and differences within those professions within healthcare. She says her thinking, like, it seems as though her perception, her observations are that registered nurses, for example, are often able to obtain management positions, but social workers, for example, are having difficulty breaking into those leadership roles, and wondering if it's a spectrum or a hierarchy of what she's called, quote unquote, women's work, whereas social work perhaps is seen as more women's work even than nursing, and then that represents an even further barrier for social workers than for registered nurses in achieving leadership positions. She's just wondering if you had any thoughts on that.
I think that's an excellent question, and I think it's really highlighting some of the dynamics. So when you start unpacking gender, and I was sort of alluding to that at the last slide in the end, that it isn't just about women, but different groups of women. So if we look at it from an intersectionality perspective, we want for there to be diverse groups of women in leadership position. That also includes diversity in terms of professional background. And absolutely, I'm a scholar of the professions, and I look at this historically. I'm a sociologist, and there has been a shift in the types of tasks and education and training and level of education for different health professions, particularly those for which women predominate. So nursing has become much more technical, and so when you talk about how nursing versus social work, that there might be a gender dynamic there. More technical work is more highly valued because that is attributed to more masculine. So that, again, is preferred and privileged in a system of gender. And so as a profession becomes more technical, it is considered to be less gendered female and more gendered male as a profession than, say, some of the very invisible and complex dynamics that happen in terms of social work. There was one example that I used in the presentation where personal support workers are considered unskilled workers, and we do a lot of observations with another team in long-term care. And the skill required for personal support workers to understand and appreciate the dynamics between different residents in long-term care that have behavior issues, that may have dementia, who sets off whom, who should be fed first, how to create a sense of calm and quiet and respectful residences in long-term care. That's a lot of skill. So the notion of skill is gendered. Therefore, the different types of activities that different professions do are gendered. So again, gender goes across all of the different layers from micro, meso to macro. So thank you for that. I hope that answers.
Yeah, yeah, we had a similar comment was posted as you were going through your answer there. Someone who's an occupational therapist had the same question and the same observation within the profession of occupational therapy. I'm also curious, when you were looking at some of the organizations and the graphs like CIHR and hospital CEOs, et cetera, that are predominantly these leadership positions that are historically male dominated. I was wondering if many of those leadership positions are filled by physicians, and I'm just wondering if that's more a reflection of medicine being historically male, that changing over the last few years, where there are now more women in physicians graduating, et cetera, and in the profession. So whether or not those leadership positions are a reflection of medicine itself as opposed, well, as much as it is gender, and whether we'll see that change just naturally as medicine changes, whether we'll see leadership positions in that area change. Any thoughts on that?
Yeah, that's a very important question. So I think what we will find is that there's an intersection between the gender of the professional and the profession that is in leadership position. So the gender of the leader, as well as the professional background of the person in the leadership position. So yes, I think we will see more women who have medical training as physicians in leadership positions. So there is a gender system and a dynamic in terms of male preference and privilege. There's also a dynamic, which, in the sociological literature, we call it a system of medical dominance, where medicine is privileged and preferred, very much so in leadership positions. It starts getting a little bit more complicated when you go into the health policy realm, which is sort of where we'd like to go next with some of this. There's a bit of back and forth as to whether or not the Minister of Health, needs to have a medical background. And there was much said when, for example, Jane Philpott, became the Federal Minister of Health, and there hadn't been a physician Minister of Health for, decades. And so, but that kind of goes back and forth. So the health policy realm, a little bit more complicated there. Healthcare, definitely. You see that dynamic. And there are, in general, because we study the health workforce, there are health worker groups, health professions, for whom there's an unhealthy level of ignorance out there about what it is that they do and how they contribute, and how their training and education can be better utilized in the health system. And I think that the more that you have leaders who recognize the diversity of the health workforce, particularly, where we're looking at healthcare, there will be greater diversity of leaders once there's that recognition of the different skills and knowledge that people bring. Physicians cannot have all of the knowledge. There's just no way that one can go to school for that long. So you need to have dietitians and physiotherapists and occupational therapists and all of the different professions that have a knowledge base. And the same argument can be made in health sciences. It's why we were quite interested in the science of healthcare, because that is where more women scientists are. And it isn't just about getting women into STEM or the bench sciences. Let's also valorize where women are in the health sciences. So looking across disciplines and recognizing the important contribution that all of the different health science disciplines contribute.
Thank you for that. And again, our occupational therapist friends have commented that it's definitely true for occupational therapy. One of our physician friends in the audience said, good question about gender in medical leadership. He says there was a report by Alberta Health Services in December of 2018 on female physician leaders in Alberta Health Services. It shows that in Alberta, females make up 37% of physicians, but only 25% of medical leaders.
Mm-hmm. Yeah, no. So at every level, and it's very interesting. What we would like to do is kind of unpack that. So where are women leaders? So women in medicine will more likely be in leadership positions in family medicine than in the medical and then in the surgical specialties. So much less likely in the surgical specialties. That's an area where the representation of women in surgical specialties has been very, very slow. And people talk about the chilly climate that exists for women. When female physicians are going through residency, it's around about the time that, that they are partnering, having children, and that is residency is not sort of a conducive context to parenting. So getting back to that visual that I had put up about the racetrack and how it becomes very, very difficult. In academia, we call that being on the mommy track. So if you have children, then you're less likely to be considered, a serious academic. And so you get channeled into more of that, what we refer to as academic care work. So doing all of the tasks that are not highly valued. Very important for the organization, like most reproductive care work is, but nevertheless not highly valued. So, yeah.
Yvonne, Jamie, Dr. Lawford, I know it's difficult to jump in when you're not all sitting in the same room, but I certainly want to just check in to see if you have anything to add to any of this conversation, give you a chance to jump in here.
Hi, this is Jamie. I think the discussion has been really rich, and we're available if anyone wants to send emails and ask further questions and access more of the toolkits and information. I know Yvonne actually had to run out for a childcare issue, so that just goes to show the sort of the nature of the work that we're doing. So yeah, if I don't have much specifically to add, but thank you all for your questions. And if there are any other questions from the panelists, we'd be happy to answer them.
All right. The next question that just came in is, what advice would you have for someone wanting to break into a leadership position, especially in a women-dominated profession that isn't just a manager of their own professional discipline? So, breaking out of your own, discipline as a nurse, for example, and moving into those broader leadership roles, either within the healthcare system or beyond. Any advice for the audience?
Yeah, absolutely. Well, and this is what we want people to be able to use the framework and the toolkit for. And one of the other activities that we are doing is trying to map our toolkit onto the LEADS framework from the Canadian College of Health Leaders, where they start by saying, lead self. So what is it, that you can do? It's a bit like that lean in attitude. So just going outside of your comfort zone. And there are women and people from a nursing background, that are part of our network, that lead organizations that are for medical specialties. So often you don't require for some of these leadership positions to have the same background as the organization. So that's really important to do. So go outside your comfort zone. Think strategically about conversations that you should have with people, and they don't necessarily have to be people that you like, but just reach out to them and see if they can open the door. So that's the sponsorship. Seek support from male allies. Create male allies. It's really the only way that we're going to move this forward, is if everybody is on board. So although our toolkit is targeting women, we are creating a companion male ally toolkit as well, because everybody has to be involved with that. So create strategic linkages individually, across organizations, and then think about, okay, what has been done elsewhere? So that's, once we can, so we will have our toolkit live and interactive. We're working with the platform with LEADS, so that will be a legacy of our project. So we just want to make sure that the tools and promising practices are the right ones, and then we will make that available for people to utilize. But everyone can kind of reach out to us and see if there's anything out there that might help. But that's the way that I would approach it. Thinking about, you first, reaching out, creating linkages with mentors and sponsors, having people open the doors for you, make the introductions that need to happen, and then build off of promising practices that you can adopt or adapt to your particular leadership path, or the path for your organization, getting your organization more airplay in terms of impacting on policy.
Well, that is actually a very good way to end this session off. We are just pretty much out of time. So I would like to hand it just back to you for one more, if you do have any last closing comments or thoughts you'd like to leave the audience before we wrap up. I think you did a great job of identifying that the toolkit will be available and the resources will be there for people and to go check those out. But is there anything else that you'd like to direct people to, what's coming up next for your research, or just anything you'd like to leave the audience with before we wrap up?
Yeah, so in our research, we really want to do the benchmarking much more clearly. So if you want to partner with us for that, if you have some data, or if you would like us to focus on a particular area, reach out to us. Do follow us on Twitter. We do post a lot. And so that's an excellent place. Do keep an eye out on the Empowering Women Leaders page on the Canadian College Health Leaders website. I mean, we will be tweeting out when there are updates to that page. And if you would like us to come and do this presentation or a particular focus from this work that we're doing for your organization, please reach out to us. This is our work and it's our passion, and we really want to move this forward.
Right. And if anyone is having trouble getting in touch with Dr. Bourgeault, don't hesitate to contact us at Children's Healthcare Canada, and we'll be happy to connect you and put you in touch. All right. So thank you very much. Again, thank you very much. A great presentation. I mean, and as I said at the beginning, it was, we hear a lot about this, but it was great to put some evidence behind this, to look at what the research is really telling us, and in the end have some useful practical tools that people can use. So we're really looking forward to seeing that. All right, so our next webinar will be on February 13th, and for that we're going to be focusing on new approaches to precision public health and differential diagnosis using cognitive computing, artificial intelligence, and big data. This webinar is going to present some research from Dr. Carolyn McGregor at the University of Ontario Institute of Technology on some AI approaches looking at physiological patterns, taking big data and applying it to personalized medicine and personalized healthcare, both in the acute care setting and in the primary care setting. So a little bit looking towards the future with some interesting topics there. And we do our webinars every Wednesday at 11 a.m. Eastern time. So it is great when you can watch live, as you do get to ask your questions that really enrich the discussion, as you can see. But if you didn't get a chance to watch live, we do record all these sessions and make them available after the fact on the Knowledge Exchange Network. So thanks again for joining us today. And hopefully we'll see everyone back here next week. Bye, everyone.